Good evening, everybody. This is Dr. S.R. Arvind. I'm speaking to you from India, and I'm the president of Diabetes India, practicing diabetes for about 35 years now. Today we have Dr. Javed Butler and Dr. Ted Wu along with us, and basically it is going to be two talks. And before that, I just would like to give you an introduction about what exactly is being planned for today. We all know the heart, the kidneys, and the pancreas operate as an integrated physiological network that together regulate the circulation, fluid electrolyte balance, and metabolic homeostasis. Dysfunction in one organ rapidly propagates to the others via the hemodynamic changes, neurohormonal activation, the RAS sympathetic tone, insulin and glucose disturbances, and systemic inflammation. Type 2 diabetes, as we know, is a chronic disorder, and the care has moved from glucocentric to comprehensive cardiometabolic and renal care. We also call it the cardio-renal metabolic link. Approach today is holistic, and as we know, there's a very strong bidirectional link between heart, kidneys, and pancreas. Obesity management, lifestyle changes, and frequent monitoring of various aspects of CRM is what we all practice today. We have two talks today. The first talk is going to be from Dr. Ted Wu, and he will be talking about interplay of heart, kidney, and the pancreas, the key insights for enhanced patient outcomes. I will introduce Dr. Ted Wu first before he starts his talk, and I will be introducing Dr. Javed Butler a little later before he starts his talk, but I'll give a brief introduction of both of them. Dr. Ted Wu is speaking to you from Australia. I think it's Sydney, and it's early morning there now. He is a senior staff specialist endocrinologist, and he is the director of diabetes center at the Royal Prince Alfred Hospital in Sydney. He is a visiting endocrinologist at Dubbo Base Hospital and an honorary professor at the Jiangzhou Diabetes Hospital in Hebei, China. I hope I pronounced it right. As well as clinical diabetes, Dr. Ted Wu has a long-term interest in both teaching and research. He is focused on novel diabetes therapies, type 2 diabetes, and type 2 diabetes, especially in the young adults and diabetes complications. He has published numerous articles, abstracts, and book chapters, and is a very frequent invited speaker to international symposia. He has been instrumental in establishing the Royal Prince Alfred Diabetes Center as an International Diabetes Federation Center of Education and the National Association of Diabetes Center of Excellence. Now, a brief introduction of Dr. Javed Butler, which was the uh, he's been wearing too many hats, and I was so impressed with his CV. Dr. Javed Butler is the president of the Baylor Scott and White Research Institute and a senior vice president in Maxwell A. and Gale H. Champit Endo Chair at the Baylor Scott and White Health in Dallas, Texas. He is a professor of physiology as well. He received his medical degree from the Aga Khan University and then completed residency training at Yale University. Dr. Butler is a board certified in cardiovascular medicine and his advanced heart failure and transplant medicine. His research interests focus on clinical trials in patients with heart failure. He serves on several national committees for the American College of Cardiology, American Heart Association, National Institute of Health, and Heart Failure Society of America. Dr. Butler has authored more than 1,000 peer-reviewed publications so far. He serves on the editorial board of several peer-reviewed cardiovascular journals. He has been cited numerous times in American best doctors list. Dr. Butler currently serves as chair of the United States Food and Drug Administrator Center for Drug Evaluation and Research, what they call as the CVER, and also chair of the Cardiovascular Research. It gives me great pleasure to request Dr. Ed to start his lecture, which is titled Interplay of Heart-Kidney-Pancreas, the key insights for enhanced patient outcomes. Dr. Ted, over to you.
Okay, thank you very much, Dr. Aravind, for your kind introduction. Apologies, my camera seems to have gone a bit funny, but it'll come back. It always does. But welcome, everybody, and thank you very much for joining us today. As Dr. Aravind has said, I'll be presenting today about the interplay of heart, kidney, and the pancreas, and looking at how this enhances patient outcomes. So, here are my disclosures, which usually take, we should leave that on the screen for 3 seconds, and then we'll move on to a second disclosure. And the second disclosure is that it is 2:30 a.m. in Sydney, and then so therefore it is the middle of the night. And you may be wondering, what could possibly be keeping me awake at this hour of the day? And the answer, as always, is diabetes, because diabetes really is a very fascinating topic, and it is something that I would like to stay up for and to talk to you about today. Now, we can start from the very beginning. What is the definition of diabetes? Well, diabetes is a disease of both impaired insulin secretion and also insulin sensitivity, and what this results in is elevated blood sugars. Now, of course, we treat elevated blood sugars, but why do we really treat diabetes? We treat the elevated blood sugars because diabetes results in complications, and the complications limit both the quality and the quantity of the life of people with diabetes. And what we want to do ultimately is to prevent the complications of diabetes. Yes, of course, treating the blood sugars, treating the numbers, treating the HbA1c is vitally important. But let's not forget, it's not the numbers at the end of the day that we are targeting. We are targeting the prevention and the treatment of the various complications of diabetes. Now, there are many complications of diabetes. There's, of course, heart disease. Very importantly, this is what will affect the majority of people with diabetes. About 75% of people with diabetes will die of a cardiovascular related disorder. Things such as myocardial infarction, heart failure, and then other vascular diseases like stroke and peripheral vascular disease leading to things such as amputation. But there are many other complications of diabetes. There are kidney complications resulting in things like nephropathy. There's dementia. There is other changes such as retinopathy. And these, as you can see in the right side of the diagram, is also almost a tornado that that will affect people with diabetes. And there are many things that can contribute to these, including things such as beta cell dysfunction, such as insulin resistance and hyperglycemia, but also not forgetting the other cardiovascular risk factors such as obesity, overweight, hypertension, dyslipidemia, and smoking. All of these things we do need to focus on, but note already that it is more than just treating blood sugar. Yes, treating blood sugar is very important, but there are other things that we need to think about when we are trying to prevent that tornado of complications that might affect patients. And then if we think even more broadly, and in terms of the numbers of people who are affected by these disorders, then more than 530 million people in the world are affected by type 2 diabetes. You can think of that as the metabolic or the pancreatic sort of issues that may be prevalent in the world. And that's a large number, more than 500 million people. And not only are there more than 500 million people with diabetes, but this prevalence, as we all know, is rising in many parts of the world, including in the Middle Eastern areas, in the Indian subcontinental areas, and in the African regions. So this is a large problem, but it's growing. Then we have cardiovascular diseases, and cardiovascular diseases are depicted here in the red. And they are a major circle. Here they've limited the numbers to 60 million, but these are failure who are not adequately diagnosed and therefore not adequately treated, mostly with HFpEF. And there's therefore a large unmet need. And it carries with it a large disease burden. Approximately 50% of people with diagnosed with heart failure would die within 5 years of diagnosis. That is a worse prognosis than some cancers. And then we've got the biggest circle of here of all, 850 million people with chronic kidney disease. So the estimated prevalence is greater than 11% worldwide. Of course, there's wide geographical variation, just like there is with type 2 diabetes. And it is often asymptomatic and therefore, again, undertreated as an issue. So all of these circles are big, in the hundreds of millions of people, and they affect all quality of life and quantity of life as well. So going back to this slide about diabetes and wanting to treat the complications, I've shown you that previous slide where the complications are in fact linked. They are not separate issues at all, but they are interlinked issues, and we should treat them as such. So while in that previous slide, I showed those 3 separate circles, in fact, the 3 separate circles should be shown overlapping with each other. The pancreatic or metabolic disorders, the cardiac disorders, and the renal disorders. They should be interlinked circles, and sometimes people have 2 of these issues, and sometimes they have all 3 of these issues at the same time. And of course, having overlapping problems will make it worse for the patient. And let's not forget all of the underlying risk factors that contribute to not just one, but all 3 of these disorders. Things such as hypertension, obesity, older age, tobacco use, and other shared risk factors such as dyslipidemia. So these are interconnected problems, and few, if any, have symptoms in the early stages, but they all lead to very serious risk of morbidity and mortality. And it is a dynamic thing. It is over time. So while I initially drew the circles as separate, well, that is because sometimes it is separate, or sometimes one of the issues predominates over the other. So for example, somebody could primarily have diabetes and very little cardiac disease and very little renal disease. However, over time, the risk factors increase, or the HbA1c goes up, or they start to develop HFpEF, and the circles increase. And they increase to such an extent that they start to overlap. And two or more of the conditions can then predominate. And then, of course, then they make each other worse. And quite often you have the coexistence of all three, the cardiac, the renal, and the metabolic complications, all being affected, all being affecting the patient, and all affecting each other as well. And thus, we will favor interventions which will target the multi-headed nature of this disease process and therefore requiring a multifactorial approach. So if we are to draw the diagram again and look at it a little bit more realistically, we should not look at these issues separately, like the 100 or so million people, with metabolic diseases, the 800 million people with chronic kidney diseases. In fact, we should look at the overlap. And the overlap is that 40% of people have type 2 diabetes and renal disease at the same time. We have approximately 2/3 of people with type 2 diabetes having cardiac disease, and up to 60% of people have CKD and cardiovascular disease at the same time, with approximately 16% of people having all three things together. So they are certainly interconnected. And just because you are treating a patient for one condition, that does not mean that there are not other conditions as well. There are often other conditions that do need attention, do need diagnosis, and therefore also do need therapeutic interventions and management as well. And we do need to manage these patients because having more than one of these disorders will lead to premature death. If we take the index here of somebody with no diabetes and a certain length of life, just having type 2 diabetes will decrease your lifespan by 6 years. Having type 2 diabetes and early kidney disease shortens your life by 9.1 years, having two diseases. But having another two diseases, having a type 2 diabetes and having a myocardial infarction or stroke, will decrease by 11.2 years. But having all three together, well, that is an even greater effect on your mortality. So it does have a large impact and a multiplicative impact on people's lifespan. But we do know ways of intervening. Now, going back to that initial definition slide, diabetes being a disease of increased blood glucose levels, well, if we treat blood glucose levels, will we improve the outcomes? And the answer is yes. It did take us many decades, in fact, many centuries, to prove that decreasing blood glucose will impact outcomes, both in terms of myocardial infarction in the red and in the kidney and other microvascular outcomes in the blue. So this is the famous UK-PDS study, which took more than 15 years, really, to go from initiation through to the publication. But in 1998 was the first publication of UK-PDS, and it showed that even in the shorter term, you have a 25% decrease in the microvascular outcomes, which was highly statistically significant, and a 16% decrease in cardiovascular disease, which was initially and disappointingly not significant. But look at the p-value, 0.052. That was very close to statistical significance, very strong trend. But the clever thing about the UK-PDS was that they extended the follow-up for another 10 years. They had the intervention group of intensive glucose control, having then the same glucose control as the control arm. In fact, what they did was that they lowered the HbA1c in the control arm and followed up for a further 10 years. Yes, we had a legacy of the continuing reduction in microvascular disease, but the macrovascular disease, the AMI, decreased by 15% and then was highly statistically significant. And yet in the follow-up period for these 10 years, these two groups of intensive glucose control and conventional control had the same HbA1c. So what this is a legacy of good macrovascular and microvascular outcomes from early good glucose control. Now, it does take quite a while to manifest its benefit. We're looking at almost 25 years of intervention before we see the macrovascular benefit at statistical significance. But if we decrease the kidney disease, we will ultimately decrease cardiac disease as well, as is proven here. Decreasing microvascular disease decreases macrovascular disease in the long term. And so if we are to prevent this tornado of complications that we were looking at before, we can think of the multifactorial approach to target the multifactorial risk factors of the complications. And you can think of it as A, B, C, D, E, and S. And at the top with A is A1C, decreasing blood glucose. So decreasing blood glucose does reduce the complications, but it's not the only thing. Because as I said, it can take a very long time for the benefit of things such as macrovascular prevention to be evident. And so therefore we do need to think about multifactorial risk factors, things like blood pressure, things like cholesterol, and things such as exercise and smoking and drugs to protect the kidneys and heart. And we'll think about and focus on D a little bit later. But there are risks. However, the thing that I would like to emphasize, and this is a very important point, is that these risks or these diseases are often silent. So in terms of the pancreas, the glucose level can go up to 15 millimoles and be asymptomatic for a very long period of time. Because of this, type 2 diabetes itself can remain undiagnosed for years and years, doing a lot of damage to the body. And even if the diabetes is diagnosed and you have a blood sugar of 14 for a number of years, that can be contributing to many of the complications, and the patient does not even realize it. Then let's take chronic kidney disease. In somebody with chronic kidney disease, whether it's from diabetes or not, an eGFR can often go down to 25. A urine albumin to creatinine ratio could be 100 milligrams per millimole, and these patients would be asymptomatic. Such a patient would already be in stage 4 kidney disease, and they do not have a symptom at all. And yet, stage 4 kidney disease is a huge risk factor for end-stage kidney disease, but also for cardiovascular disease as well, and will be making cardiovascular disease worse. And then what about cardiovascular disease? We've often seen patients with a 90% coronary stenosis who may be asymptomatic, and the first sign could be a sudden, severe myocardial infarction, an event that might be devastating to the patient, may even kill the patient. So we have diseases that are interlinked, we have diseases that are severe, and yet diseases that are asymptomatic. So what should we do? We should be screening patients, because if we do not detect these problems early, then we cannot treat them. So what about screening? Well, the WHO has many criteria for screening disease conditions, including things such as the fact that a disease process is asymptomatic early on. If a disease is obvious, then we don't have to screen because it will declare itself. However, if a disease is latent or asymptomatic, if there's a suitable test, if we have a treatment for the disease that we're screening for, then there should be screening programs. And examples of screening programs are for things such as And we have big in the world. It's not just kidney, also urine human ratio. And if you have certain be risk the high or the areas in the red need to have raised, maybe say albuminuria with a normal EGFR to be at high or very high risk. And that's on EGFR and urinary ACR when screening for kidney disease. So going back to this slide where we have asymptomatic diseases, we really need to emphasize screening. And we emphasize yearly screening for complications of type 2 diabetes when somebody already has developed type 2 diabetes. And that's because we need to diagnose who or identify who has the highest risk of developing these complications. Because we now have drugs which target the heart and the kidney for treatment, not just of diabetes, but also for the treatment of the cardio and the renal complications of diabetes, treating both the heart and the kidney, as well as treating diabetes itself. So if we look at the interplay or the sort of overlap between the cardiac disease and the renal disease, and look at the metabolic disease contributing to this, SGLT2s can cover all three. There's overlap of the complications, but there's overlap of treatment, where a single treatment can target all of these things at the same time. And it's a very timely point to be discussing this, because right now is the 10-year anniversary of the game changer in diabetes trials, the EMPA-REG outcome, which was announced at the European Association for the Study of Diabetes meeting in Stockholm almost exactly 10 years ago in September 2015 to a standing ovation. And why was it a standing ovation? Because if you think about the context of EMPA-REG outcome, every drug trial prior to EMPA-REG outcome, the drugs that treated diabetes could lower blood glucose, and lower blood glucose, remember, can decrease cardiovascular disease, but no single diabetes medication drug could show a benefit over that of just glucose lowering alone, indicating that you could use any medication to treat blood glucose. They would all have the same benefit in terms of kidney and in terms of heart outcomes. But no single diabetes agent could show benefit over and above that of standard of care of any other diabetes medication to improve outcome for cardiac disease. But why did EMPA-REG outcome have a standing ovation? Because as you are all quite well aware now, this famous outcome where empagliflozin decreased 3-point MACE by 14%, hazard ratio 0.86, statistically significant, decreasing cardiovascular outcomes over standard of care, because placebo arm had the best standard of care as well, and proving for the first time that a diabetes agent could have additional cardiovascular benefit as well as glucose lowering as well. And it's not just that. There were many trials that followed EMPA-REG outcome, which used empagliflozin or Jardiance. There was the CANVAS program with canagliflozin. There was DECLARE TIMI with dapagliflozin. There was VIRTUS with ertugliflozin. Some of them could also show a benefit in terms of 3-point MACE. Some of them did not. And some of them showed a benefit in terms of heart failure. Some of them showed a benefit in terms of kidney outcomes, and some did not. But only empagliflozin EMPA-REG outcome hit all of the targets, including cardiovascular death. There was a 38% and highly statistically significant reduction in cardiovascular death using empagliflozin in the EMPA-REG outcome. And you can see in the purple box that empagliflozin is the only one which had benefit in terms of all of these cardiovascular outcomes. And this was compared to the best standard of care at the time. So the only difference was either the addition of empagliflozin or the addition of a placebo, with all of the other diabetes medications being up titratable, being able to be added during the trial. And this has led to, around the world and in some regions, maybe not in your region, but certainly in the US and in Australia, there's an indication for empagliflozin for reducing cardiovascular death. And then we had the hypothesis generating reductions of heart failure and nephropathy as well, even as early as 2015 for empagliflozin. but they needed to be primary studies in heart failure and kidney disease as well. And indeed, those were done. So very quickly, I won't bore you with a lot of trials, but empagliflozin showed reductions in reduced ejection fraction heart failure, reduced outcomes in EMPEROR reduced, and also improved outcomes in EMPEROR preserved. And again, standing ovation, because empagliflozin was the first medication ever to show a benefit in preserved ejection fraction heart failure. And then onwards to kidney disease. Well, here's the EMPER-Kidney study, which showed a slowing of decline of eGFR. In this graph, higher is better, and empagliflozin in the long term, in a very high-risk population, decreased eGFR by minus 1.37 mils per minute per year, whereas in placebo, the decline was 2.75 mils per minute per year. So you're halving the decline of eGFR over time, a 50% reduction. But not only that, here's a very important point. If you start empagliflozin at an eGFR of 20, you delay the onset of dialysis by about 1.9 years. And that's great, okay? But that's a very high-risk population. And you can say, high-risk population, of course you're going to have a benefit, okay? eGFR of 20. But what if you started with an eGFR of 85? Now, this is an extrapolated analysis, but people who took placebo have an eGFR decline of this trajectory and will get to dialysis by about 20.8 if they have a high urinary ACR at baseline. But if you give empagliflozin, it takes 47 years, extrapolated, to reach the same eGFR of 10. You have saved 26.6 years of dialysis. And what does this mean? In a high-risk population, it's never too early to start empagliflozin. So you can start SGLT2s late in the disease process to slow development or worsening, but you can also start it very early as well. It's never too early and it's never too late to start SGLT2s. And so all of this evidence has changed guidelines. It's changed guidelines in diabetes, in cardiac disease, and in renal disease, and in other disease processes as well, such as in liver disease. So let's go back again to the past. Let's go back to the American Diabetes Association guidelines in 2006. And these guidelines have everywhere HbA1c set greater than 7%. You can see in those ovals. The HbA1c greater than 7% is everywhere. And every time the HbA1c was over 7%, you did something. Right? Using older medications like metformin, insulin, sulfonylureas, etc. But the main thing that you can see here is a very glucose-centric approach. Everything is focused on HbA1c. Everything is about lowering glucose and emphasizing monotherapy, metformin, and just stay on metformin and lifestyle for a long time. But why is there that glucocentricity? Well, that's because that's all we had evidence for at the time in 2006. But in the EMPEROR outcome, it's been shown that only a small percentage or proportion in the blue of the improvement in EMPEROR outcome can be explained by HbA1c lowering. The other bit, the purple bit of the decline or the improvement, is from empagliflozin itself. A very small percentage is for HbA1c lowering or even blood pressure lowering or other risk factor lowering like LDL and impacts on triglyceride. The vast majority of the mediation analysis showed that the benefit was from just being on empagliflozin. So that leads to the notion that there's something particular about empagliflozin and the SGLT2s that protect the heart. It's not just from glucose lowering. And that means that the current ADA standards, and this is from this year's standard of care, if you look very closely at this, there's very little that focuses on glucose. And no longer is it just saying, oh, HbA1c and focus on metformin and things like that. That's just this part of the diagram. Instead, it's focused on the complications and the targeting of treating these complications. So ASCVD, heart failure, CKD, management, and glycemic goals. Yes, glycemic control is still important, but on this part of the diagram, manager and glycemic goals. Yes, glycemic control is still important, but see, on this part of the diagram, manager and glycemic goals. Yes, glycemic control is still important, but see, on this part of the diagram, manager and glycemic goals. Yes, glycemic control is still important, but see, on this part of the diagram, manager and glycemic goals. Yes, glycemic control is still important, but see, on this part of the diagram, so SGLT2s are now very much emphasized by guidelines around the world. And so we've looked at this, we've looked at the ADA and the EASD consensus report, which follows the ADA. You know, they do that consensus report in conjunction with each other. You've got the cardiac guidelines that have SGLT2s as the first line of treatment in people with type 2 diabetes and heart failure. You have the kidney, the KDIGO guidelines, the ADA KDIGO guidelines, the ADA EASD consensus report in people with kidney disease and diabetes. SGLT2s should be the first line of therapy. And you have more generalized guidelines, the primary care guidelines and position statements that, of course, emphasize SGLT2s in people with heart disease. And people mature HV met for people starting and that's HbA and it can improve this and majority before trying to says monthly this for year ones that can benefit if said we know the target of so of therapy inertia. Other inertia cause its effect patients and clinicians, then clinicians lack tools to deal with side effects. So some of the effects and how to. So the first thing people have been worried about is that acute dip in EGFR. We now know that you can decrease EGFR up to 30% when you start an SGLT2. But the thing is that this is normal and expected for SGLT2. It's just like ACE inhibitors or ARBs. We are decreasing intraglomerular pressure and we are improving long-term outcomes. And in fact, now we know there's no need to increase EGFR monitoring. If your patient has 6-month EGFR monitoring, continue on 6-month monitoring of EGFR. You do not need to do an EGFR 2 weeks after you start an SGLT2 inhibitor. And some of you may be thinking, well, what about acute kidney injury? If you decrease EGFR, surely you increase acute kidney injury. Well, this is the highest risk population of all. This is the EMPA-Kidney study. And in the EMPA-Kidney study, empagliflozin was shown to have a 22% decrease in the risk of AKI. Look at that, a 3.2% risk of AKI for EMPA versus 4.1 for placebo. So that's a 22% reduction in AKI. And in this study, empagliflozin was continued even if the EGFR dropped below 15. And so in this very, very sick population, very high risk, empagliflozin decreases AKI. Now, the next thing that people worry about, urogenital infections. Now, these are usually genital fungal infections. They are not UTIs. Can I emphasize that? They are not urinary tract infections. They are genital fungal infections. And they're usually very easily treated and preventable with things like good hygiene and over-the-counter medications. So unless they are recurrent, then urogenital infections really should not be limiting the use of SGLT2s. And you can do things such as decrease the HbA1c by other mechanisms first, such as sulfonylureas, and then add the SGLT2s, and then take the sulfonylurea away, because that decreases the excess glycosuria early on. And the last thing is ketoacidosis, a rare but severe side effect of SGLT2 inhibitors. And that's because SGLT2s increase ketone production. And we need to be aware of sick day rules. The easiest way to prevent DKA is to know your sick day rules. So if someone's fasting for surgery, or if they're ill and they cannot eat or drink, then you stop the SGLT2s. But SGLT2s are not the only medications that need to be stopped. Here is an acronym, SADMANS. So you can see in SADMANS, SGLT2 is the last S, but we do need to stop the SUs, the ACE inhibitors, diuretics, metformin, ARBs, and NSAIDs whenever someone is dehydrated, when they're sick, or if they are fasting for surgery. 3 days before surgery, we stop the SGLT2s 3 days before surgery. But the important thing, the box down the bottom, we really should be restarting once they're eating and drinking again, because these are such beneficial medications. We should not be withholding them from our patients. So the summary of my talk is that diabetes is a condition of high blood glucose, but also a disorder where there are complications. And the interlinked complications of the heart, the kidney, and the pancreas are often silent but severe, and therefore we need to screen them if we want to treat them effectively early. But the most important point here is that SGLT2s, such as empagliflozin, are increasingly recognized as an effective early treatment for the heart, the kidney, and the pancreas, are promoted by multiple guidelines, and we must use them early and avoid clinical inertia. And with that, I thank you very much for listening. I'll be on for questions and answers later. Thank you.
Thank you very much, Dr. Tech. I think that was a very comprehensive coverage of, you started with what is type 2 diabetes, and what's been the defects, and then you have beautifully took us to an era where empagliflozin really made a big mark. It was almost till 2004, 2005, we were only looking at, the glycemic part of it, and then 2005, 2006 came the gliptin era, and then we started talking about no hypo, no weight gain, and 2015 onwards, it was all about, but I think I can also answer. The question is very simple. When a CRM, what are the tests that we need to be doing to the patient, especially with type 2 diabetes, to make sure that we start an SGLT2, and how often should we do this?
Okay, so one is easier than the other, and as I said, at least yearly we should be looking at things. For the kidney, it's easy. It's urine ACR and EGFR, and if either one of those show an indication for SGLT2, then we should be using them. For the heart disease, there's an easy answer and a more difficult answer. The more difficult answer is how do we actually screen for asymptomatic cardiovascular disease? That's a whole lecture, and I'll leave that to Professor Butler. However, the things that you don't know, such as lipidemia, such as hypertension, obesity, or indeed early family history, smoking, all of these things are high risk of atherosclerotic cardiovascular disease. In those people, the guidelines say that is enough to promote the use of SGLT2. Anybody with multiple risk factors for cardiovascular disease and diabetes should be treated with an SGLT2 and or GLP-1 receptor analog.
Yeah, I think the second question is a little tricky question. How do we harmonize the guidelines of CRM so that it's applicable probably region-wise, probably world-wise? I think it's very difficult to, how do we harmonize the CRM guidelines and to be applicable to a large, population of patients with type 2 diabetes?
That's either guidelines really data only last 2022 have the guideline really reflected the clinical trials and take a little bit longer before all the disease processes come together and harmonize guidelines. That's it. I agree. A bit more difficult.
Thank you very much, Dr. Ted. And I think I'll just move on to Dr. Javid Butler now, because he will be starting the second lecture. And his second lecture will cover basically the spotlight of the cardio-renal metabolic aspects, and it's going to be the patient care series. So I'm sure many of the audiences will get the answers to what they were looking at. Over to Dr. Javid Butler.
Well, thank you very much. I am at the American Heart Association meeting here in New Orleans, hotel setting. So I'm going to do this from and the loading up the slide. So my first comment is that Dr. Arvind, you are way ahead of your times here because multiple professional societies are actually now working on CRM guidelines, right? So if you look at it, the primary care guidelines, the cardiology guidelines, the endocrine guidelines, the nephrology guidelines, they're all kind of sort of saying the same thing, but there's a little bit of sort of trick that, somebody is emphasizing on this and somebody is talking about those clinical trials. And the question is, wouldn't it be nice to have just singular CRM guidelines? I suspect that the first CRM guidelines are going to be out within the matter of next 12 to 16 months. So they're going to be out pretty The slides are being loaded now. Okay, great. So I can see the slide. So can we go to the next slide? What I would go, both of these cases are really not famous. Check about are the cases that you and I see on a daily basis in our clinical practice. So this is really one of the cases, but once we start sort of thinking about things, one can realize that there is a lot more to be learned even from these simple cases. So let's take the first case. So 74-year-old female, history of hypertension, diabetes, very common, comes into the clinic, complain, and by the way, this is a real case. Comes in complaining of, getting more tired, short of breath. I'm just not feeling the same, but nothing dramatic is going on. The ability to be able to do things at home that they were able to do very easily, they are now finding some difficulty in being able to do those things. The patient is a little bit overweight, BMI of 28. The exam is pretty much unremarkable with one exception, and that one exception is that they have some lower extremity edema. So, because of the symptoms, they checked some routine labs, ruled out hypothyroidism, make sure that the person is not anemic for some reason. The patient was not a smoker, but out of caution, they did a chest x-ray. The chest x-ray was normal. So the clinical decision in the primary care setting was that the lower extremity edema is probably because of amlodipine that you're taking for hypertension, and that you should maybe lose some weight and do some exercise. Now, that may be a pretty reasonable explanation, and that explanation may be true, but there is one issue here. One issue here is that the person has been on amlodipine for quite some time and has new onset edema. Can you really blame it on amlodipine? Maybe, maybe not, but kind of makes you think a little bit. And then the second thing is that when you rule out hypothyroidism, something big with the lungs, chest x-ray, infections, and anemia, do you stop the evaluation of shortness of breath and tiredness at that point, or do you go to the next level? And I think it is very common in the primary care setting to, at this point, do exactly what was done to this patient. Can we build the slide? So now this person comes to the follow-up, and a couple of months later, again, nothing dramatic is going on, except that the person is now a little bit more tired, a little bit more short of breath, and nothing really has changed per se. So that prompted the clinician to check pulmonary function test and an echocardiogram. Pulmonary function test and echocardiogram were both normal, and there is a reason why I have the word normal in the quotation marks here. I'll come to that in a minute. But the bottom line is that the clinician was told that the echocardiogram was normal. There was no natriuretic peptide that was measured in this person. Again, something that would be not uncommon in primary care. Next slide. Okay, so now 3 weeks later, the person presents to the emergency room with a stroke, was found to be in atrial fibrillation. No idea how long the atrial fibrillation has been going on. So no cardioversion, was started on beta blockers for rate control, started on anticoagulation, and because of the stroke-related deficits, was sent to the rehab facility. At that time, cardiology was also sort of concerned, and we looked at the echo, and indeed, the ejection fraction was normal, but the echo was not normal. The ejection fraction was normal, but the echo was not normal. The echo reports had left ventricular hypertrophy, left atrial enlargement, and mildly increased pulmonary artery systolic pressure. RV function was normal, however. However, we are so ejection fraction focused that when it was heard that the ejection fraction was normal, the rest of the echo was basically just let go of that the EF is normal, so the echo is normal, and the problem is not with the heart. At any rate, the patient in the rehab facility had a few bouts of recurrent atrial fibrillation and then ended up getting a Foley catheter and then had infection, and one thing led to another, and eventually, basically, the patient passed away. And my sort of argument here is that all of this, literally all of this, could have been avoided because if we would have had heart failure, atrial fibrillation, cardiovascular, all of these things in our mind and have a low threshold to assess those things, as opposed to saying lose weight and we'll follow up. You will find it pretty interesting that there are two studies out now, one in UK and one in US, that about 70% or so of new onset heart failure is diagnosed in the emergency department. People come up with shortness of breath, whatnot, edema, have high, pulmonary congestion, they get diagnosed. And then people went back and looked at the medical record over the past year. And of the 70% of the people who got diagnosed in the emergency department, over 80% of them had some signs and symptoms that were consistent with heart failure that was mentioned, that was recorded, but the workup was exactly like this patient, that other diseases were ruled out, but nobody thought about a heart failure per se. And this is one reason that heart failure, because its signs and symptoms are so overlapping with normal aging, with obesity, and with other diseases, that people don't think about it as much overall. I would posit a case for you that this person likely had paroxysmal atrial fibrillation, definitely had left ventricular heart failure with preserved ejection fraction, and earlier diagnosis and earlier treatment could have completely changed the trajectory of this person's disease. Next slide, please. So, was this clinical course inevitable? Should this person have been screened for heart failure? Should this person have been screened for arrhythmias? Should somebody had looked at an echocardiogram a little bit more carefully and not just say it's normal because the ejection fraction is normal? And could an earlier diagnosis of HFpEF, earlier treatment with an SGLT2 inhibitor, and now even more therapies are coming on board, and I'll talk about that, could that have changed the course of this patient? And I am hard pressed, but to say anything that yes, it would have been a completely different course for this person, and this person may have been alive today if we had that lower threshold. Next slide, please. Okay, so here is the way to think about heart failure. So if you think about it, we have been thinking about prevention of vascular disease for a long time, right? So we think about treating myocardial infarction, but we think about preventing myocardial infarction. We have, Framingham risk score and prevent score and high risk classifications and when to give statin therapy and what dose, and all of those things we have done. But when it comes to heart failure, we don't think about prevention of heart failure, right? It's all about treatment of heart failure. And the question is, why not think about prevention? Now, part of the reason it is because historically we have thought that heart failure is a consequence of ischemic heart disease. So if you're focusing on prevention of ischemic heart disease, then by definition, you're focusing on prevention of heart failure. That mindset has really changed now. Indeed, it is true that ischemic heart disease is one of the big reasons for development of heart failure. It is, however, is about a 50-50 case. Almost half the patients who develop heart failure do not have manifest vascular disease like myocardial infarction, stroke, angina, TIA, claudication, none of that. Now, I don't know who has subclinical coronary disease, but at least they don't have any clinical coronary artery disease. And in this era of obesity and diabetes and CKD that we're living in, a lot of the people develop heart failure without the traditional ischemic heart disease. So to promote that, what we have decided, now it's been over a decade now, to have this staging system for heart failure, with the stage A being those people who are pre-heart failure at risk for it. So this is high blood pressure, diabetes, requiring some sort of chemotherapy for breast cancer that may affect cardiac function, etc. Then stage B is where stage A, those risk factors have progressed to actually affecting the heart structure and function. Left ventricular hypertrophy, left atrial enlargement, high PA systolic pressure, all three of them were demonstrated by this patient. Atrial fibrillation, diastolic dysfunction, all of those things. So this is at the junction of developing heart failure. Now, when we talk about things like myocardial infarction, we have a good sense the chest pain started and you had a heart attack. When we have a stroke, there is a good sense that the person was walking fine, talking fine. Now they have slurred speech. Now they have, some problem. With heart failure, the challenge is that the start of heart failure is much more gray, right? It's not black and white that you had heart failure and that you did not have heart failure. And therefore, having a low threshold of assessment beyond symptoms is really, really important. And I would say that this person not only had stage A characteristics, high blood pressure diabetes, stage B characteristics with structural functional cardiovascular changes, but on top of that, this patient had stage C in which they have symptoms. So stage C is what a symptomatic heart failure is, shortness of breath, tiredness, and fatigue. And then stage D is advanced heart failure, where we think about transplants and VADs, and people are basically non-responsive to medical therapy. So what do you do in the primary care setting when you find somebody, or in the non-cardiology setting, when you find somebody with shortness of breath, tiredness? If you want to initially rule out, anemia, hypothyroidism, that is perfectly fine. But these enriched patients, we really need to have a low threshold to go to the next level. And perhaps even better than checking for an echocardiogram is just to check a natriuretic peptide level. Remember that the American Diabetes Association now recommends annual assessment of NT-proBNP precisely for this reason, that the sign symptoms are non-specific, and to have a lower threshold for further evaluation, and then doing an echocardiogram on these patients further. Now, Dr. Wu mentioned a point which is really worth its weight in gold, because it's a really important point. And that is that, yes, as a cardiologist, I would say that you need to do an echocardiogram. You need to find out whether it is heart failure with reduced or heart failure with preserved ejection fraction, whether you need an ICD. All of those things are fine. But here, in high-risk patients for prevention of heart failure, we need a drug like empagliflozin. Remember, this person with hypertension, diabetes, EMPA-REC outcomes, this person is a candidate for empagliflozin anyways. And empagliflozin and SGLT2 inhibitors were the first therapy that have shown benefit in both HFrEF and HFpEF. So we don't even need to wait for the evaluation, and starting that person on something like an empagliflozin would be very helpful for both pre-heart failure or undiagnosed heart failure. And oh, by the way, because SGLT2 inhibitors have diuretic properties, it might also help with the edema and congestion and shortness of breath as well. Next slide, please. Now, Barry Barlow and other colleagues have sort of come up with some of these scores when to suspect heart failure with preserved ejection fraction in the community setting. They first came up with the H2PEF score that had BMI, high blood pressure, atrial fibrillation, pulmonary hypertension on echo, older age, and higher filling pressures. So this person has all of these characteristics, and they have a scoring system, and the higher the score, the higher the likelihood of HFpEF. I, along with many of my other colleagues, kind of found this score to be of limited utility, because you actually needed an echocardiogram to be able to get to filling pressures and pulmonary hypertension, so not as applicable in the primary care setting. Next slide, please. So that led to the colleagues developing a second simple score called ABA, which is basically age, body mass index, and atrial fibrillation. Now, the good thing about this is that it is very simple. And boy, if you have these characteristics, you basically have heart failure with preserved ejection fraction, and our patient fulfills exactly this criteria. Having said that, if you don't fulfill this criteria, does not mean that you don't need to worry about heart failure per se. You still need to worry about heart failure. This has a very good positive predictive value, perhaps not as good negative predictive value. And I would again urge that if available, assessing natriuretic peptide in these patients is probably one of the best things that you can do. Next slide. Now, heart failure tends to be a multi-organ system involved disease. Remember, at the end of the day, circulation, attaches all the organs with each other. So it's not uncommon to have high CKD, high diabetes, high insulin resistance, high pulmonary and congestion and respiratory muscle abnormalities, high liver abnormalities. All of these things sort of tend to go hand in hand in patients with heart failure. The reason I mention this is that once you have a diagnosis of heart failure, keeping a low threshold to look for other disease states and vice versa. If somebody has other disease state, but not all the symptoms could be explained on the basis of that disease, understanding subclinical cardiovascular involvement may be a good practice. Next slide, please. Now, this slide highlights the fact that when we talk about high-risk patients like type 2 diabetes, we worry very appropriately about vascular complications like MI, stroke, coronary disease, and we should. However, what we tend to forget are things like peripheral vascular disease and heart failure. And in fact, heart failure is the second most common presenting symptoms. And I can guarantee you, although as a heart failure doctor, I'm biased, but I can almost guarantee you heart failure is number 2 and not number 1, only because very much like the patient that I just presented, heart failure is underdiagnosed. And if we were to systematically do natriuretic peptides and make the diagnosis, especially of heart failure with preserved ejection fraction, the proportion will be even higher. Next slide, please. So why am I focusing on heart failure so much? Well, a couple of points. One is that the patients with heart failure, once you develop heart failure, Dr. Wu gave some really compelling statistics, mentioned that the prognosis is worse than many forms of cancer as well. But let's translate that into absolute numbers. You know, sometimes when we talk to our patients with relative risk reduction, they may not totally understand what does a 35% relative risk reduction means. If you look at it in absolute terms, if you develop heart failure, doesn't matter whether heart failure with reduced, preserved, or borderline ejection fraction, even if you're in your 60s, you're talking about losing more than a decade of life as opposed to an age, sex match control who does not have heart failure. And even if you're an octogenarian, even if you're in your 80s, you're talking about 2, 3, 4 years of life overall loss. So this is a huge loss of life. What that highlights us is two things. One is that if you are a high-risk patient but have not developed heart failure, we really need to do everything we possibly can to prevent the development of heart failure. So we have data with SGLT2 inhibitors in type 2 diabetes. We have data with SGLT2 inhibitors in CKD, two enriched populations for development of heart failure. And the second thing is that once you do develop heart failure, realize that these patients are at an extraordinarily high risk and sort of jump at these patients as soon as possible to give them appropriate care to change the trajectory of their disease. Next slide, please. The other problem with patients with heart failure is that while as clinicians we are appropriately concerned about mortality and hospitalization, remember the patient-reported outcomes, their symptomatology is also equally important. In fact, many studies show that patients rank their symptoms even higher than hospitalization and mortality, a good proportion of them. And there is this serial link, right? So you have, what is the cardinal symptom of heart failure? Well, shortness of breath and fatigue. Well, what does that do? Well, that makes me more difficult for me to walk around and do things. Well, what does that do? Well, if I'm unable to do things, then I'm unable to do things which are essential, like bathe, shower, take my meds, but more importantly, from patient's perspective, unable to do things that I enjoy doing. You know, go out and play with my children, grandchildren, go to work, go to religious ceremonies, whatever it is. Well, if I'm unable to do things that I really like to do, then guess what happens? might start getting depressed. So you can see this serial chain of quality of life and its impact that is affected by patient symptoms. So other thing is to give effective therapy is to stop this sliding scale escalation of worsening symptomatology for these patients. Next slide, please. Now, heart failure with reduced ejection fraction is easy. Yes, we can do a whole lot of workup for the etiology and why the EF has dropped, but heart failure with preserved ejection fraction is kind of a little bit of a tricky thing, right? Because your ejection fraction is normal and people miss the diagnosis. And that is why but this patient was basically just told to lose weight and do sort of nothing more. So this is a little bit of a complicated slide. If you're comfortable in non-cardiology setting to evaluation, there is really not rocket science. In any primary care or non-cardiology specialty setting, you can do that. On the other hand, we also realize that you may be stretched and you may be busy doing other things. And if you want to refer to cardiology and work with them, that will be fine also. But if you have somebody with normal ejection fraction, signs, symptoms consistent with heart failure, and have a structural heart abnormality, the first thing to do is to make sure that there is not an alternate cause of these things. So, cirrhosis, GFR less than 15, advanced kidney disease, all of those things can cause that kind of scenario. If you have ruled that out, and remember, at the end of the day, we are clinicians. More often than not, life is not black and white. Like I gave you a completely black and white example, GFR less than 15. Well, what about GFR 32? It's not normal. In those cases, make sure to go to the next step and not just blame it on GFR of 32, because you're not going to have many people with GFR of 95 and you're not going to have many people with GFR of 14. It's going to be in the middle. So the next step is, other than HFpEF, is there any other reason which is cardiac but could explain constrictive pericarditis, tight aortic stenosis, hypertrophic cardiomyopathy, amyloidosis? So if those things are ruled in, then they have their own specific therapy, obviously. And if those things are ruled out, that's when you have this garden variety cardiometabolic HFpEF that needs to be treated with appropriate medical therapy. Next slide. So what is that appropriate medical therapy? Well, that is an evolving paradigm. So if you look at the last set of American guidelines, which are incredibly delayed in being updated, at that time, the only class 1 recommended therapy was a diuretic therapy, and there was only one trial that had come out with an SGLT2 inhibitor. It was class 2A, and everything else, the trials were basically negative or neutral, and therefore, on the basis of subgroup analysis, ARNI, MRA, ARB, they were all sort of a class 2B recommendation. Next slide. However, as we know, the landscape has evolved. At this point, there is no controversy that SGLT2 inhibitors in HFrEF, HFpEF, acute heart failure, chronic heart failure, regardless of diabetes, no diabetes, CKD, no CKD, none of those considerations, unless contraindicated, all patients with heart failure and preserved ejection fraction should be on an SGLT2 inhibitor. And as I mentioned, the good thing here is that you don't even need to wait for the echocardiogram, because it doesn't matter whether it is heart failure with reduced or preserved ejection fraction or pre-heart failure, an SGLT2 inhibitor is recommended in that patient population. Next slide. And now we have a positive trial, one positive trial with MRA. So maybe it's a combination of an SGLT2 inhibitor and MRA, and this will continue to evolve over time. Next slide. So I won't belabor on EMPA-REG outcomes trial. Dr. Wu already mentioned that. That trial was positive for prevention of heart failure, progression of CKD, but importantly, reduction in cardiovascular death, 35% relative risk reduction. And guess what our patient had? hypertension, diabetes, and cardiovascular death. And that's why I think that earlier therapy could have prevented that. Next slide. And what about heart failure, not prevention of heart failure? If you have heart failure, SGLT2 inhibitors have a class 1 recommendation. Can we go back a few slides to the guidelines? More? Yeah. So there's a class 1 recommendation now for SGLT2 inhibitor across the spectrum, regardless what the ejection fraction is. Next slide. This is based on 2 large outcomes trial that convincingly showed reduction in mortality, morbidity risk, emperor reduced and emperor preserved. Both of these not only were highly statistically significant, as you can see here, but a very clinically meaningful result, a 20+%, 25% relative risk reduction in both trials. Next slide. But the important thing from our case perspective is not only the benefit, but how early the benefit occurs. And as you can see here, the curves started separating really early. In fact, in Emperor Preserved, the first time there was a statistically significant separation of the 2 curves was day 18, less than 3 weeks. Next slide. And in Emperor Reduced, it was day 12. Day 12. So this whole dynamic that you see a person who has an indication and you say, well, why don't we think about it and let's do it when we do it, come back for the next visit in 3 months, is actually exactly the wrong thing to do, because we are putting our patients, unfortunately, at a higher risk because these benefits accrue relatively very early. Next slide. It really doesn't matter what subgroup you are in. We have looked at in every possible subgroup, basically no heterogeneity: sex, region, base, race, diabetes, CKD, COPD, baseline use of ARNI, baseline use of MRA, baseline use of ICD. Really doesn't matter. All of these patients benefited. Next slide. If you have heart failure with reduced ejection fraction, you basically improve ejection fraction. We talked about functional capacity. Your 6-minute walk distance improves once you give an empagliflozin or SGLT2 inhibitor. Next slide. And finally, the quality of life scores improves substantially, improves early, and improve in all domains. And by all domains, I mean both symptoms, symptom type, symptom frequency, and functional limitation that leads to improvement in quality of life scores overall. Next slide. And when started in the in-hospital setting, even in the in-hospital setting, because of effective diuresis, unless the only caution was that the patient was not on inotropes or crashing or requiring IV vasoactive therapy, but could still be getting IV diuretic, starting it in the hospital setting in the short term, there was a significant, statistically significant benefit in terms of short-term improvement in mortality, hospitalization, and quality of life benefit. Next slide. And then when we take these clinical trial data and apply it to the registry setting in the outpatient, so, one of the concerns always come up, well, all of these data are good, but they are kind of sort of in a clinical trial environment. Do you see the same benefit in the real world? And the answer is absolutely yes. Multiple large registry observational data have basically replicated the benefit of these therapies in the real world as well. But in the interest of time, I won't spend too much time about the lack of use. Dr. Wu covered this whole issue of inertia very eruditely, and it is now up to us in the clinical community to implement these therapies. Next slide. And this is my last slide to just highlight that, when I sort of round with the medical students and you ask them, what would be an ideal medication for a patient? Well, these are the characteristics of an ideal medication, right? It's one pill once a day, no dose up titration, doesn't matter what background medication that you're on. It improves clinical outcomes, it improves quality of life outcomes, it improves symptoms. The benefits are early, and you might give it for one disease or another, but it impacts multiple organ systems and is tolerated well. And an SGLT2 inhibitor will fulfill this criteria. Now, I have a case too. Dr. Irvin, I have about 10 more minutes to go in this session.
I think so. We still have about 10 minutes or 15 minutes, and then we can take 10 minutes discussion.
Perfect. So we'll move on to the next case. So I emphasized a lot in the first case because it really is something that happens in the primary care setting all the time. Now, the second case, I won't go over as many slides, but rather than talking about data and science, this case is all about the art of medical decision making. Again, a very common case. The previous case was HFpEF. This case is heart failure with reduced ejection fraction. I will give you my opinions and conundrums, but will not say what is the right or the wrong thing to do. I think it will be a good discussion with the group over as well, because we can do this case in many different ways. I will just give you my opinion. So this is a 66-year-old patient who comes to the clinic. The person came into the hospital, had about some weight gain, shortness of breath, decompensated heart failure, was treated with IV diuretics. They lost about 7 pounds, were feeling well, and they were discharged. Now, unfortunately, another common thing we see in patients with heart failure, that while hospitalization is a great time for us to be able to put them on good medical therapy, it is worldwide, globally in the registry, we have seen the same thing over and over again, that basically people, the only thing we do for these patients is to give them diuretics, and they come into the hospital on suboptimal medical therapy, and they are discharged on suboptimal medical therapy. So this person basically got diuretics, got their weight loss, and then they went home. Their EF was about 32%, and at the time of discharge, they were feeling well. And by the time they came back to the clinic, they had NYHA class 2 symptoms. So they were doing pretty okay. Next slide, please. Their past medical history is ischemic heart disease and diabetes, hypertension, CKD. And here is the medication. So if you can just focus on the medications a little bit. They were on valsartan, sacubitril, 4951. So that's good. They're on ARNI, but they're not on target doses. Beta blocker, 12.5 BID. That's good, but they're not on target doses. Furosemide, 40 twice a day. So pretty healthy dose. They are not on MRA, and they are not on an SGLT2 inhibitor. So two-drug therapy is still, unfortunately, the most common combination for heart failure with reduced ejection fraction. They have some shortness of breath, they have some orthostatic dizziness intermittently, but really overall they're doing pretty well. They really don't complain much of symptoms. Next slide. So here is where the art of medicine starts, right? So they have some orthostatic symptoms. They are on sub-target doses of beta blocker and ARNI. Their blood pressure is not bad, but borderline, 100/70. Their heart rate is 70. Well, that's sort of borderline, and I'll explain to you in a minute what I mean by that, borderline. Their JVP looks like upper limit of normal, but they're overweight, kind of difficult to assess, not that easy. They have a soft mitral regurgitation murmur. They don't have any ascites, but they do have a little bit of edema, not a whole lot. Their potassium is 5. Technically speaking, potassium of 5 is not necessarily a contraindication for MRAs, but all of us will worry about the risk of hyperkalemia. GFR is 31. Again, technically speaking, if you were a literalist, you will say, well, that's not a contraindication for an MRA, but we all will worry about hyperkalemia risk in this person. Their NT-proBNP is still high, so they clearly are congested. Their QRS is not wide, so they're not candidate for CRT therapy. Next slide. So this is my last slide. And the question is, what do we do with this person? And there are many things we can do. We can say that why don't we increase the dose of ARNI? They are not on therapeutic doses. We can say increase the dose of beta blockers. They are not on therapeutic doses. We can say add an SGLT2 inhibitor. We can say add ivabradine. We can say add an MRA. We can say add a combination of a potassium binder and MRA. We can say this person, although on 40 BID of furosemide, that's not enough for this person. Their NT-proBNP is still 1100. Just go up on furosemide for now and do nothing else. And we can say that this person has worsening heart failure and we need to add vericiguat in this patient. You can also take a stance and say, let's do all of this. Let's see this patient on a weekly basis. This person is at a high risk, and let's do all of these things. I'll give you my opinion on this and would then love to see what everybody's input is. So let's just start from the top. ARNI. Yes, going up on ARNI is a reasonably good idea. There was a secondary analysis done, not randomized data, secondary analysis done, and it looked like that the low, intermediate, high doses of ARNI, all three of them benefited for the patient. My personal bias would be to not increase the dose of ARNI on this patient now. Now, in the future, if this person stabilizes, I'm not saying not to go up on ARNI. We should really try to get to the target doses. But right now, there are some other urgent needs, and I would put that in the back burner. Increasing beta blocker is a really, really interesting idea. Remember that the best mortality benefit is when you are physiologically beta blocked, which would mean basically having a heart rate in the low 60s. And this person's heart rate is 70. So this person is not beta blocked right now. The problem here is that with beta blocker, your congestion is likely going to get a little bit worse and your blood pressure will become an issue. So a few things. You might consider switching from carvedilol to long-acting metoprolol that does not have alpha blocking properties and may not have orthostatic or blood pressure lowering effect overall. I think that going up on beta blocker is a good idea overall in the long run. My personal bias would be to increase beta blocker first before ARNI. But I would say let's keep it for visit 2 or 3. Right now, let's just continue with the current doses of beta blocker or switch to metoprolol equivalent doses, but don't go up. Third, add an SGLT2 inhibitor. That is a no-brainer. This person should have been not leaving the hospital without an SGLT2 inhibitor. Fourth, add ivabradine. Now, that's an interesting thing. Some people would argue because of the risk of hypotension, ivabradine will control heart rate, and you may not need to go up on beta blocker and render this person beta blocker intolerant at this point. Ivabradine indication is EF less than 35, normal sinus rhythm, and maximum doses of beta blocker. This person's EF is less than 35. This person is in normal sinus rhythm. But I would say the preferable choice rather than complicating polypharmacy is to go up on beta blocker in the next 2 or 3 trip, not start him on ivabradine. MRA is really interesting. This person can really, really, really benefit from an MRA therapy. However, this person is at an extraordinarily high risk of hyperkalemia. So if available, then potassium binder and an MRA combination would be a good idea in this person. I would not increase diuretic in this person because the GFR will get further worse, and some of the diuresis you will get with an SGLT2 inhibitor. Let's see what happens. And then finally, because this person is unlikely to be able to tolerate an MRA or an ARNI, an early initiation of vericiguat in this kind of a person would be a really good idea because it is very well tolerated. So this sort of highlights that medical decision making is not exactly a guideline algorithm. You have to kind of individualize it to a patient, and all of these things could be the right answer in the right patient, right combination, and right time. So I will stop here. I really have to apologize that I don't know what's happening with my internet, but hopefully with this cell phone, my audio was reasonably clean. Thank you so much.
I think they have to close the slides. Yes, I think is that. I don't see any questions coming on the chat. Cardiologists, is it time to go for a different type of training at the medical school level? Because too many times the patients move from one consultant to another and the ideas differ. In fact, the last case that showed, I think you as a cardiologist, you were thinking was totally different. I don't know what okay, I would have added an SGLT2, but then is it really the time to look at the way the doctors are getting trained? Because diabetes is becoming more and more comprehensive in management.
Boy, this is such a thoughtful question. So, can I take the liberty of giving you four answers, not one answer?
Yes, please.
So my first is, I think we should look, and this is entirely a criticism on my cardiology community. We are so enamored, appropriately so, and again, I mean, we have tremendous progress just in my lifetime in interventions and devices and procedures. We really don't think about cardiology as much and the number of things and of options that we have. So the first thing, regardless of the new training paradigm, even cardiology practice and other specialties, and I would say the same thing is relevant also. They are looking at a various line of nephrology and dialysis and earlier management and prevention in subspecialty training. So that's answer one. Answer two, is that subspecialty training, so regardless whether you are trained in nephrology or cardiology or endocrinology, having a superimposed 1 year of subspecialty training, which is cardio-renal metabolic, would be really great. I'm having visualizing that training with need to be more before AI sort of would make exactly hard to next thing. Allogliptin, it wasn't statistically significant, but again going in the wrong direction. But with linagliptin and sitagliptin, there was no signal and were completely safe from a heart failure perspective. So that's where the clinicians are sort of really stuck. So my best answer that I can give you is that these are not exactly the same molecules within each class. You are better off giving it the drug that has been shown to be of benefit in the clinical trial. But if you don't have access to that medication, then some drug in that class would be a good idea as well. Don't totally omit it.
Yes, totally agree with Professor Butler there. The problem is that sorry, my picture went funny again. You can only look at the evidence that's in front of you. And the clinical trials, the randomized trials, are not the mechanistic trials. So we cannot say what or what. All we can do is that we can look at the data in front of us. Now, I will caution one thing. Remember that these large cardiovascular trials are powered for the primary composite endpoint. When you are talking about CV death, you're looking at one component of that composite, and the power is much smaller. Now, it is nice when a component of a composite endpoint is statistically significantly improved, but that does not mean that something else which does not prove it, that does not mean that it's useless. As long as it falls within, the confidence intervals fall within the point estimate of a meta-analysis of these agents, then you can say that the effect is consistent. Now, I will always caution about this thing of every single agent in a class is the same. You know, Professor Butler gave some examples. I'll give you an example from diabetes. Rosiglitazone and pioglitazone. They are in the same class. They have the same mechanism of action, but one of them increases AMI, one of them decreases AMI. And that's partly because one of them increases lipids and one of them decreases lipids. And so you cannot just assume that every single agent in the class behaves the same. The evidence is there for us to say that in its primary cardiovascular outcome trial, empagliflozin showed a reduction in CV death. But you know what? In the renal trial for dapagliflozin, there was a decrease in CV death as well. So there are more similarities than differences within the SGLT2 class. That does not mean, I'm not saying that they're all the same. And certainly there is an indication in certain jurisdictions for empagliflozin for reduction of CV death. And that's because that's what the evidence is. But unfortunately, the question is it a molecular effect or difference in study design? Look, I think that we don't know the answer to that. And it could be the play of chance because we are looking at an underpowered result from a composite endpoint.
Yeah, I think there's a very interesting question. Is it safe to give spironolactone in patients with heart failure with reduced ejection fraction and CKD? And what happens to metabolic acidosis?
Well, yeah, so that's a tough question, right? So I don't know about the metabolic acidosis part. That's above a cardiologist's IQ. But I can tell you that this is going to become more and more of an issue. So there is a trial going on with finerenone in heart failure with reduced ejection fraction who are intolerant to spironolactone. So not exactly a head-to-head trial, intolerant, but we will get some data. But in the meantime, this issue comes up, is that if you have diabetic kidney disease and HFrEF, and you have benefit from finerenone in one and spironolactone in the other, which MRA do you use? I will give you my answer, and again, this is opinion, this is not data driven, this is opinion. There is no particular reason to believe heterogeneity of heart failure effect between steroidal and non-steroidal MRA, but there is a significant difference in spironolactone effect across the EGFR categories in secondary analysis of the existing data. So on the basis of this, if possible and if available, I would go with finerenone.
Yeah, I think the third question again is just to augment the diuresis in an acute heart failure case, can I start with 25 milligrams of empagliflozin?
That's actually a really interesting question. So if you look at EMPA-REG outcomes trial, the 10 milligram and the 25 milligram in the long run had no differences in the clinical outcomes, and that's why we chose 10 milligram for all the CKD heart failure studies, and the trials are positive, and that's fine. But the person who's asking the question is actually asking a little different question, and that is, will 25 have more diuretic property in acute heart failure? So now the issue is not the 5-year outcome. The issue is, a 10-day outcome. Will you have more diuresis? And the answer is yes. You will have more diuresis, especially remember that there are two ways SGLT2 inhibitors cause diuresis: osmotic diuresis and sodium hydrogen exchange blockers, so natriuresis. The osmotic diuresis effect is especially potent if your blood glucose is not controlled in patients with type 2 diabetes. So, yes, you can have some incremental diuretic benefit, but I think that they will be marginally enough that it's probably not worth it, and just giving 10 milligram as a chronic therapy is good enough.
Yes,
Yeah.
again, I completely agree with that. And remember that the indicated dose is 10 milligrams, and that's because the 10 milligram dose was the one studied in heart failure. It's interesting to note that the side effects are not increased at 25 over 10. And so that was proven in the EMPA-REG outcome as well as in clinical practice. In our patients with diabetes, I see no more side effects at 25 than 10. So you could use it, but the standard dose is 10. You can still use 25 with confidence.
The last question wants to know whether you can start empagliflozin for prevention of heart failure or in pre-heart failure. I mean, there's nothing called a pre-heart failure. I was wondering, but I thought I'll still ask you the question because it has come from one of the audience.
100% yes, in two populations of patients. One
Yeah.
is patients with type 2 diabetes, another the patient with CKD. Definitely empagliflozin will prevent heart failure. Now, the question is, if you don't have type 2 diabetes or CKD, and you are otherwise high risk, family history with pre-diabetes and hypertension and this, that, the other, we don't have the data for that.
Yeah, and indeed the clinical impact may be smaller because the absolute risk is smaller. I mean, if you've got no cardiac disease, renal disease, or heart disease, or diabetes, then the absolute risk is low. So why would we be bothered about that? But I totally agree. EMPA-REG outcome, EMPA-Kidney, DAPA, CKD, all of these do show reductions in hospitalization in heart failure in those without a baseline history of heart failure. There may be an undiagnosed heart failure, especially HFpEF, but certainly they were undiagnosed.
So thank you so very much, Professor Tendru and Professor Javed Butler. I don't see any more questions, and then we have also ended the time extremely well. And if there is any final words to wrap up from the Boehringer Ingelheim team from UAE, they can do so. Otherwise, I can close this session. I thank both of you. We had great time, and then I'm sure we'll catch up with another program soon. And I don't know what to say, Ted. I mean, it's good morning or already early hours of morning, and Javed is right in the middle of a conference, and I have to go to bed. Okay. So,
All right.
good night from my side, and thank you so very much.
Thank you.